I'm going to go ahead and get started. So, good day and a welcome to our cardiovascular imaging weekly conference. I think this is the beginning of the year. And for those of you who watch us on various networks, it's usually a beginning of imaging for the whole year. So what we usually start with is each one of the imaging modalities going through what constitute that modality, how do you make an image, what are the pros and the cons and artifacts and various things that go into it. So from echo to nuke, CT, MR, all these imaging modalities. Then talk about disease entities and how does each one of the imaging modality fit in our understanding, imaging, pros and cons, and then towards the end of the year talk about futuristic developments and where does the research take us down the line. So today is on ultrasound, something dear to my heart. I know I've given this lecture for a few years and always add something, to it. Yes, the basics don't change, but the technique has improved and evolved so much that now we have a family of imaging techniques within ultrasound that can go from just taking a look at an image to reconstructing it and putting it in 3D. 3D is amazing. And the amazing thing to me is that all these evolution in ultrasound is still under the same premise. It's really the same premise, which is I send a wave and it is in the ultrasound frequency, so you and I don't hear it. It's not in kilohertz, it's in megahertz. So that this wavelength that you see on the left is very, very small. So at the beginning, we're going to start thinking is, what is this technology about? How do you make an image? And then how do you evolve from making a simple image to even taking it to put an image of a heart or almost any other organ, biologically that you're taking a look at. So few basic things. One is this is a wave and it is usually defined by its wavelength, okay, and its amplitude. So the wavelength that you see there is called a cycle, one cycle of a wave. The amplitude can be an oscillation, wide oscillations as opposed to the small oscillations, okay? And you could see the longer wavelength versus the shorter wavelengths. And there's a definition of frequency. The frequency is the number of cycles per second, and that's hertz, okay? You talk about kilohertz and megahertz. So the frequencies that we use for ultrasound is in the megahertz range, and usually between maybe 1.5 to about 7 or so megahertz. That's clinically for ultrasound, cardiac ultrasound. The interesting thing is the higher the frequency, the lesser the energy that you have and the less penetration. So you have to play around with the penetrance of an organ for you to be able to image it, because at the highest frequency, you may have an incredible definition, but you may not have as much power. And to tell you also, you need to know that you can have frequencies in the 30 megahertz, even 50 megahertz range. So a very, very small wavelength, which improve your resolutions almost like an ultrasound microscope. So, but these are very thin, basically a microscope using ultrasound as opposed to just imaging, okay? So, need to know also that the way you know depth when you put your ultrasound transducer is you solve for the velocity. So I send a little spurt of ultrasound. It goes and hits an organ and it comes back. And if I know what the speed of ultrasound in biological tissue and how long it took for that burst to come back, then I know its depth. So whenever you look at an ultrasound and see depth in centimeters, etc., basically it's solving for the equation of speed within, and how long did it take for you to look at the image. And the properties of ultrasound are similar to any other wavelength, and could be light, it could be any other things, could be electromagnetic, it could be ultrasound, and it has the same properties of reflection, refraction, similar to light. So I did a little animation for you this time. So you like to have a little change. So this little animation, you have a transducer. And what's in a transducer? It has, I know you don't usually open what's the transducer inside, but it has all these piezoelectric crystals that are, I mean, it's a science by itself. And nowadays, it's not excited anymore mechanically. In the early days, you excited mechanically, it's excited electronically, and now, you know, very nicely synchronized. But basically, these crystals are responsive to electricity. So you excite it a little bit, it emits a certain frequency, and that's how you initiate, you know, this ultrasound that you send. Now, when you send this packet, see this packet of ultrasound, when you send it to a surface, it's going to do almost the same thing as light. It's going to hit it. If there's no surface, if there's nothing else to hit it, it's going to keep traveling till it dies. You need to know that ultrasound doesn't travel well in air. It travels very well in fluid. But just imagine if the surface is very reflectant, just like, you know, calcium or metallic things, it's going to bounce back quite a bit from it. So besides bouncing back, most of the time it can travel through, just like if you shine a little wave on a surface of water, it's going to be deflected. So this is refraction. And then reflection is, you know, almost symmetrical to the perpendicular on this. So you see this being reflected up. Now you can say to yourself, how can all this wave is going away. I'm not registering anything that comes back. Why? For you to be able to see an image or solve the equation of this ultrasound coming back to you, it's going to come back to the transducer itself. And what you see in little red, and I put it deliberately in thin, is that a very tiny fraction of what you send will come back to you. A very tiny fraction, okay? And that's why it's so important for you to understand it, because quite a bit of that energy is going away. And it's going to hit different structures, and the structures are moving, so they're going to bounce over each other. And at times you may see reverberations, you may see mirror imaging, you see other things. Basically, you're sending this pulses of ultrasound in this medium, and this chest wall, and this abdomen. And it's amazing, actually, that we could discern various structures within, you know, these various cavities. Okay, so that's the principle. Now, how do you image? It's very interesting. I grew up, you know, in Lebanon with mountains and all that stuff, right? So if I send an echo, my voice, if I talk loudly and I wait, if I keep talking loudly and whistling or screaming or whatever it is, you're not going to hear, you're not going to discern well what the reflection of the sound is off a cliff. Okay? The way you're going to be able to hear it is you send a burst, it travels, you wait for it, it hits, comes back, you hear it again. So it's almost like shouting against yourself. You're not going to be able to tell how far is a certain structure if you keep sending waves continuously. That's why we send waves in packets. So a packet is maybe 3 or 4 of these wavelengths. They travel, they hit, they reflect, they come back to you, you analyze. Another packet. And it is not that long. We're talking about fraction of milliseconds, right? So they are sent so fast, but they're not sent continuously. That's how you image with ultrasound. Why? Because you need to solve for the reflection, so I know where to place this image, this little dot. So let's go through them. What are these modes? A mode, you probably haven't heard about it, but it's called an amplitude mode. An amplitude mode, so I send this little burst or packet, and I have a red one that has properties less reflectant, maybe muscle, as opposed to a calcium on the right side. The calcium is more reflectant, so I'm going to see a much more amplitude of this. So this is the amplitude mode. It reflects, come back. What's the intensity of this? So I can plot it as an amplitude. So in the less reflectant, it will be much less intense. and the more reflectant one will be more intense. That doesn't help me much, really, to image well, but this is how it started, believe it or not. A B mode, which is brightness, so I flip this vector that is like this, I flip the vector towards you, so it becomes a brightness mode. So then the more reflectant one will be more bright compared to the other one. Now, intuitively, we started thinking of, oh, more bright means, I'm taking an example, it means more calcium, meaning more fibrosis, meaning more whatever it is, compared to a few red cells that barely reflect anything, or a soft myocardium that is nice and soft, right? So you can discern the differences. Now, what's an M mode? M mode is for motion. M is for motion. So if I take a look at this dot, okay, and I look at what is happening to this dot in time. If the dot is stagnant and I have an x-axis of time, it's going to stay like a line. Nothing is moving. But if this dot went from here to there, I'm going to see this motion over time. So you could see it down at the bottom. It just goes up and down. And that's your M mode when you look at what happened to the septum or the posterior wall during the cardiac cycle. If you have an akinetic segment, it's going to look like this. If you have somebody with very good function, you're going to see the endocardium go up and then go down, right? So this is it. That's your M mode. So this is my M mode of looking at the aortic valve, and the aortic valve closes and then opens, and if I give it a little time domain, it's going to look like a box, and then closes again, and opens again, and closes. Look at the septum, look at the mitral valve. I mean, I know quite a few of you are familiar with this, so basically we don't want to belabor the point. It's basically, it's your brightness giving it time along the line of my scanning line. I'm sending this transducer just one line, what's going on, what's reflected, what's going on in time. Now, how do you put a 2D image? Well, you put a 2D image by thinking along the line of, remember my scan line, now I move my scan line next, and then next, and then next, and then next, and then next within a sector. And then I'll do it again, and I'll do it again. I'd like to do it as fast enough so then I can look at this heart, since it's moving, and almost as real time. And with time, with parallel processing and so many other things, your frame rate of how often can I update this can be in the 60, can be in 100 range, so it's pretty close to real time. Okay? So if I look then at my 2D, this is what my 2D is a bunch of scan lines, and you can have almost 160 of these scan lines within your 90-degree sector. You could say to yourself, why do I have a 90-degree sector? Well, we want to look between the ribs. You have other transducers that are linear transducers that are just sending ultrasound in a parallel fashion as opposed to a scanning fashion, and that's great for carotids, for abdomen, other things where you don't have issues with ribs that you have to go between the ribs for you to be able to see it. If I had a linear, like a box, I'm going to see shadows of the ribs, and because the ribs are bony, right, they're going to reflect most of the ultrasound, so I'm going to have a black under each one of them. Okay? That's your imagination of what would a linear ultrasound look like. Okay? So let's talk now a little bit about resolution, which is now very important. So we're getting to some of the practical terms. You have two examples of one, a higher frequency on the left side and a slower frequency on the right side. So you just imagine if I have two dots, okay? If I have two dots, I'm going to say I'm imaging these two, and these two dots are indeed separate. They're not one dot. They're actually two. You could see the relationship of the wavelength to the dots. If I have a long wavelength, smaller, lower frequency, right? I'm not going to be able to differentiate them. They're going to look like one dot, which is the yellow signal on your left side. Okay? So in this situation, these two are going to look like this. And when I use a higher frequency, I'm going to differentiate them that they are indeed two. And that's your axial resolution. That's your resolution. So when I put a transducer on my chest, and I'm going to take a look at the aortic valve and see the fine points, and there is a lesion that is 2 millimeter, right? If I use a very slow, very low frequency, you're not going to be able to differentiate it. You're not going to be able to tell these are, they're going to look like a blob. And you could see that actually when you change the frequency on your transducer. Go to higher frequency, 3.5, 5 megahertz, 5.5, 6 megahertz. The image looks so refined, so fine, as opposed to more globular the lower the frequency you're dealing with. So I think these are important from an acquisition point of view, okay? And when we talk about axial resolution, it is along the line of that scan line. So I'm perpendicular to that. Why? Because this is where frequency is very important. Now, you can already tell that there is another resolution that we have to deal with, which is the lateral resolution. In a lateral resolution, just imagine each one of these piezoelectric crystals is sending waves, but what happens? Dispersion occurs, right? So you're going to get a wider tube, as you could see here on the right side. It's a non-focused beam. It's going to be bigger and bigger and bigger, right, away from my transducer. And what happens with that? If my field is then big, right, I'm not going to be able to discern these two. They're going to look like one. That's why your resolution in the far field is really blurry, because your lateral resolution becomes an issue. Okay? So this is differentiating dots that are parallel as opposed to one on top of another. Now, one thing is there's a button on your machine called focus. Where's the beam focus? So you can focus a beam, okay? It's almost like a lens technology. You could focus it electronically to look smaller, narrower, and therefore improve your lateral resolution wherever you want it. We usually don't play as much with it. Most of the time you put it in the middle of the chest, whatever it is, but at times you may want to focus it to try to improve a certain resolution of a structure that you're dealing with. Okay. So that's, in general, as much basics. I mean, there will be also something about harmonics, but all the first 5 of these, overall gain, and I know at times you play with overgain, time gain compensation. It's a nice word. You know, these buttons that you have, that you slide back and forth to increase the gain at a certain depth, although you think about them are depth, they are time, okay? Because if you increase a certain, amplitude, it is at a certain depth or time. That's how you solve the equation. So it's called time gain compensation, lateral gain compensation, reject and compression. All these are post-processing. I already sent this energy down to interact with my structure, and I'm getting this energy back in my transducer, and I'm processing it, okay? All these are not influencing what you sent. What you sent, okay, is already built into the machine, but there's one thing that you usually play around with, which is the mechanical index, or the output power. But few other settings are already occurring in the machine. Is the packet size. You talk about this packet, the packet size that goes in there. The line density, a word that you don't think about, but sonographers may think about that. A line density meaning how many times I go up and down on my line of scan before I move to the next one. And the more I interrogate, obviously I slow down my frame rate, but I'm more accurate in depiction of whatever it is I want to depict, be it imaging, be it Doppler, be it whatever it is. So line density. And the other one is the output, how much energy, power I'm sending down, all right, because I need power to be able to penetrate the chest wall and so many other things. So the last one, which is your mechanical index, is the one that you're more familiar with because it interacts with many things, including bubbles if you're using contrast, and you can destroy them. Now, we use energy-safe ultrasound for cardiac imaging because you could increase the energy so much that you could be destructive. Destructive. You could break down red cells, you could injure tissue, we know that, and you use it in different other, biological implications for that. You could have lithotripsy with ultrasound, right? You can focus the beam and then, have so much energy to destroy anything that you want to do. So it is, it is regulated within a certain range that is, that's important from a safety point of view. So the mechanical index is peak negative pressure divided by square root of frequency. And, I know we use this for bubbles, and we'll talk about bubbles, but you could see that if you have something that is deformable, on the peak pressure at the beginning, right, what happens? You have higher pressure, and therefore you compress, if it is compressible, the bubble. And then on the negative one, you just basically expand it, and you could destroy a tissue depending on the amplitudes, right, of these oscillations that you're sending. A few other things that you need to know. We talked about reflection, reverberation, attenuation. I think this is beautiful here because you have two phenomena in the same picture. You have attenuation and you have reverberation. Okay? Attenuation is when the reflection of this, and this is a prosthetic valve here with a thrombus on top of it, and this is where the suture line and the ring is. And if the reflection is incredibly strong, right, it will reflect all the ultrasound, so nothing goes through, nothing is refracted. Remember, you have to depend on the refraction to see beyond it. If nothing is refracted, I'm not going to see anything. It's all black. Now, it's interesting that there are some tissues, particularly prosthetic valves, the mechanical ones, that they reverberate. They reverberate, and then within this little thin one, ultrasound kind of goes back and forth, and gives you this lineage here that's called reverberation. So these are two artifacts that frequently you will see. Not artifacts, but these are properties really of ultrasound. And remember one thing, I know you're advanced, for Doppler, if you are attenuating, you're attenuating almost everything. I can't see beyond this calcification. Therefore, also, I can't see if there's any Doppler, if there's any flow, if there's anything else that you're processing. So it's important to keep that in mind, because if I can't see almost anything that I'm going to ask from my instrument to tell me. Interestingly enough, is at times also you may have reverberations with the casing of the transducer. So the transducer, I send the ultrasound, it goes down and then gets back, and it gets reflected back from my transducer, which has casing and everything else, goes back and forth. So you may have at times reverberations here. That's why this apex doesn't look as good. And interestingly enough, we're going to talk about harmonics. Harmonics takes care of that. So, and that's why harmonics has been so useful, is, it takes care of some of these reverberations. And if you're really not sure of what it is there thrombus, is there something hiding, you have to change your angulation so you get away from these reverberations that you have, or you could use contrast to try to improve it. Here you go, on the left side, that's the same case. There was some suspicion that there may be a thrombus here. We didn't know that it was real. Use contrast and it improves the situation. And technologies have evolved. It's really amazing. I mean, in the history of medicine and history of mankind, this technology has not been there for too long. And if we have time, I'll show you the first ultrasound that was done by Dr. Edler himself. But we're talking about 1950s. 1950s. And an incredible, improvement in everything else that we use based on the same principle. The principle is I use ultrasound, reflect it, and then analyze it whichever way. So you could see to the power of computer technology. So we have fully digital system. I lived them, believe it or not, before. We used to in videotape, and we laugh and reminisce at times in the Echo Lab of how things were. Videotape from the huge one to the smaller ones, etc. very high frame rate. In the past, the frame rate, even for 2D, was on the low side. So now you could have parallel processing, image quality, better penetration. You have multi-frequency transducers. In the past, you used to have multiple ports. And I have a 2.5 megahertz transducer dedicated, and then a 3.5, then a 5, and and then which one should I switch? And the sonographer says, well, I don't have much time to do this. I'm going to stick with one of them. But now you could change the frequency because each one of them has multi-frequency transducers. Harmonics, very important. Tissue Doppler, we'll talk about that. Digital image storage, real-time 3D. Harmonic. We'll talk about it's very important. Nowadays, most of our imaging is done with harmonic technology. If you tell me about one thing that has occurred in ultrasound that the adaptation was almost instantaneous, within 1 year, most of the imaging modalities have switched to harmonic imaging. It is harmonic imaging. And it was discovered, like many others, serendipitously. It was developed for ultrasound bubbles and then found a nice application in regular day-to-day imaging. And that's the beauty of it. And what is it? Well, we talked about frequency. If I send, my fundamental frequency is the main frequency that I'm sending out of the transducer. Let's say that my fundamental frequency is F. I send it and it reverberates somewhere and then it comes back. It's interesting. After it interacts with this object, the frequency doesn't stay the same. It may be in multiple or even fraction. So that's second harmonic, you see 2F. Third harmonic, much lower amplitude, or ultra harmonic, which is half of the original frequency. I'll give you an example in my audio. If you're a guitarist, if you're a piano player, you could strike your string in a gentle fashion and you're going to emit fundamental frequency of that, whatever that string is. Okay? If you hit it harder, you're going to alter the frequency that's emitted after you hit it harder. It will have the fundamental and it will have multiple and even a fraction of. So that instead of the sound being bang, nice and beautiful and single, you'll have bang, wow, 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 wow. Okay? So that's an example of frequency. So why are we talking about this? The interesting thing is it was developed for contrast. And the interesting thing is that obviously these tiny microbubbles reverberate a lot, compress and expand, compress and expand when you send it, and said, if I use harmonic, meaning I send my fundamental, and instead of listening on my fundamental frequency, I listen in second harmonic. Then I'll have a stronger signal coming out from my bubbles as opposed to the tissue, and therefore I image wherever these bubbles are going, be it the cavity, be it the muscle, be it whatever it is. Right? The interesting thing is that we did not think that the myocardium per se will emit second harmonic. We thought that is much more inert. Nothing will happen. Interestingly enough, it emits second harmonic too. But still, the contrast is much more vigorous second harmonic than the muscle. And the beauty of it, and you could see, this is an old picture, probably we should update it at some point in time. This is the same patient, fundamental imaging, tissue harmonic on the right side. See the clutter I talked to you about in the proximal area? Much nicer definition of this hypertrophic cardiomyopathy apical type with almost like a spade distribution. So I want you to take a look at it, right? Now the interesting thing you need to know, I know we don't emphasize as much, but when I tell you, all right, I'm imaging at 3.5 second harmonic, and it usually has an H or something like this. My fundamental frequency is half of that. And therefore, my resolution is altered down a bit. That's why things may look a little thicker. So you have the pro and con of using a fundamental that is low frequency, but the advantage of harmonic taking away the clutter and making the image much nicer. And people have looked at the thickness of the mitral valve and the aortic valve and how they affected and all this. Yes, it's a little more affected. But clinically, I think the use of harmonic has really outweighed the non-use of harmonic for regular day-to-day imaging. Now, each one of these we will talk about down the line. We talked about contrast, a few months ago, and you could see where contrast is. It's really very strong and very powerful. And but I wanted to show you a few things regarding harmonic versus non-harmonic for contrast imaging. Let's take a look at that. Okay. So on the let's see here on the left side, okay, I've used contrast, and I'm imaging with fundamental imaging. Okay. So using fundamental, I don't think any one of you is liking this image. Right? Watch what happens if I use harmonic within just a second apart. The signal from contrast increases so much. I still have a decent signal from the myocardium. However, the differentiation between contrast and myocardium is so much better. Now I take a look at wall motion. I could do, whatever it is, quantitation you want to do. Okay? So nowadays, most of our ultrasound machines are set up for contrast imaging. So takes you to harmonic, it sets it up, sets what the mechanical index is and everything else. So it helps you overall. But all what I wanted to show you is that this is the same case, right and left. Just 1 second apart, when I flip on harmonic versus non-harmonic, the image is very much different. So understanding what goes behind the scene is important from an imaging, almost any imaging. Ultrasound is even more crucial for that because there are a lot of knobology that you are doing. Yes, MRI and CT and all this will have their own knobology to do it. So we talked about imaging, okay? That's the first half. Second half is talk about Doppler, its applications, and a few other things. So let's talk about Doppler now. It's very interesting because I sent this ultrasound, and it went there, and my first question for this half hour was, how fast did it reflect? How intense was it, so I can put it in the space and I can give it a certain brightness to it. And then I can follow, obviously, if the heart is moving, not moving, et cetera, et cetera. Doppler is actually asking a different question from the same frequency that you sent. And that's how you build pulse Doppler, spectral, color, and continuous wave. And the little thing in town, I went to Salzburg where Doppler, remember it's not an acronym, it's a last name of a physicist, Christian Doppler. And that's what's left of where he was, Christian Doppler. And you could see when he was born and when he died, just imagine, 1800. And his house is almost across the street, on the same side of the street from Mozart. Okay? Just imagine this conglomerate of power of either art, music, physics. And the way he figured this one out, the Doppler equation, is by observing, there was not much pollution then, observing the stars getting closer to each other or not. There's a Doppler shift occurs. And just imagine was able to construct, the Doppler equation. And we'll talk about the Doppler equation. So the question then in Doppler is, I sent this fundamental frequency, and if there is a moving object, that's the principle of Doppler, this frequency is shifted. So I sent, let's say, 3 megahertz. If there is a moving object, it's going to change it, but it's not going to change it by a lot. It will change it in the kilohertz, in the audible range. That's why if you're passing by the Echo Lab, you're going to hear it. So that frequency shift is occurring in the audible range. And the beauty of this equation and trying to understand it is, if this moving object is going, I can tell 2 things, at least, from this shift. I can tell the direction, if an object is coming toward, if you're trying to hit me or go away from me, okay? And I can tell conceivably also the speed. So I can direction as well as speed. So if you're out on Main Street here or Fannin, and the train is coming or the siren is coming, You could tell if it's, close your eyes and you'll be able to tell that this is coming towards you or going away from you. Because if it's coming towards you, frequency goes up. And then when it starts going away from you, it's going to go down. So instead of bzzz, constant, it'll be like, right? So coming towards you, you can hear it from a car at times, it goes up and goes down. So I can tell how fast also, because if I go up and down very fast, I know it's much faster car or train compared to something else. So this is the depiction here. It's basically if the object is coming towards you, I'll have a positive shift in frequency in the kilohertz range. If it is going away from you, it will be a negative 1 in the kilohertz range. I kept this because this is Mike Quinones's drawing. And Mike, I don't want to date this, but maybe about 20-some years ago when he used to give this lecture. And you could tell here that, I take my Doppler one side, I get a positive reflex from the shift in the ascending aorta, and I get a negative shift in the descending aorta. And this is the Doppler equation. You don't have to remember it. I don't think it will be on your, but I think you have to remember a few things. One is that the Doppler equation is actually a frequency shift. You see it on the left side. It's a frequency shift depending on the velocity, the frequency, and cosine theta, which is the angulation. Remember when I told you that for best axial imaging for ultrasound, you have to be perpendicular. Cosine theta of perpendicular is 0. So the best time I get the maximal frequency shift is when I'm parallel to the structure. Just like if you're sitting in the street and the car is coming towards you directly and going away from you, as opposed to me sitting here and listening to the cars going back and forth. You're not going to hear any frequency shift. So you have to be in the line of flow, right? So that's the importance of cosine theta. And that's one importance. The other one is V, the velocity, is solved. In the early days, the y-axis on your ultrasound machine was frequency, it was not velocity. Now it is solved for you, assuming that cosine theta is 1, right? Meaning that you're parallel to flow. If you're not parallel, you're going to have to figure this one out one way or another. Okay? And when does it become important? Because above 20 degrees, cosine theta becomes important. So you'd like to be within 20 degrees of this. Now, where is that important? Certainly aortic stenosis, right? You don't know where the jet is going, and you want to try, the apical window, the suprasternal, the right parasternal, the subxiphoid, trying to figure out the highest velocity, which tells you this is the lowest angulation that you have. Okay? So that's in general Doppler. So I'm asking a different question now. Send the ultrasound. When I hear back, I'm listening to say, hey, how much frequency shift occurred? Right? If it is high, the velocity is higher since it's directly proportional. If it is low, provided that I'm not at a significant angulation. Okay? So let's take it to the real world. Pulse Doppler. What does pulse Doppler mean? Meaning I have a region of interest right here. This is the region of interest where I'm interested in what's happening to this velocity. So how do I do that? Well, remember this packet? I send this packet. Goes down. I send it down. I don't do anything else. I just sent maybe 1 or 2 packets and that's all. And I wait. I wait for the time that it would take for this packet to go down and up again, and then I listen. Okay? So that then if I wait that duration, therefore I know I'm at that depth, and I listen and see what happened to the frequency shift. Did it change? Did it go up or it go down? That's pulse Doppler. It's range gating, so I know what the gate is, and I wait in between. And the beauty is, you apply here fast Fourier transform analysis for you to be able to solve the frequency shift into what you see right there. And this is what's called a spectral display, meaning Each one of, supposedly, of these red cells are going at this speed. So in the LV outflow tract, the vast majority, early on when you have fast ejection, all of them are aligned, all of them are going at the same speed. Then it'll start decelerating, so you have this spectral broadening, right? And then, finish there. Okay? And then your applications, we'll talk about all these various applications. This is now looking at the mitral inflow, what happens with mitral inflow, etc. Well, there's a limitation to pulse Doppler. If the velocity is very high, I'm not going to be able to resolve it. So at least I need my pulse repetition frequency. This is called a term you need to know. Pulse repetition frequency is how often I can send this pulse and listen. Send, listen, send, listen. You can tell already if I'm closer to the transducer, my pulse repetition frequency can be much faster. If I'm further out, I have to wait a little longer. And it's the same principle of stroboscopic imaging. If you go to a disco, whatever it is, and you're imaging only in stroboscopic, if you have a high frequency, I can tell the motion of an individual. If I have a low frequency and the individual is moving much faster, I cannot tell which direction they're going. I could be completely fooled. I could be almost in the reverse reaction. Same thing with movie cameras and so many other things, right? So you need a certain frequency in relation to the velocity of these red cells or the muscle for you to be able to do that. Okay? Now we could do some tricks. I mean, here and that's the phenomenon of aliasing. If I can't resolve it, it's going to wrap around. It's going to look funny. If the velocity is much faster, I can't tell a thing. But at times, I can reconstruct this. I could do my baseline shift. I shift this baseline to look at only one direction because I know, let's say, in the LV outflow tract, velocity is going in one direction. I can shift my baseline to be able to allow to see the whole velocity in there. However, if I have a mitral regurgitation jet, just like here, the velocity is so high, no matter what I do, it's going to be like red cells all on top of each other, and I have to use something else, which is continuous wave Doppler. So we talked about that. How about color? Well, color is very interesting because now it's not only one sample volume somewhere. I'm looking at a certain area of interest for flow. I'm still using pulse Doppler technology. It's very interesting, but I'm using a crude way of pulse Doppler. Okay, it's a quick estimation of velocity and direction. And it took a couple of years for people, believe it or not, to agree what color to give it. There was some camp that said blue is coming towards you. No, red coming towards you. Okay, we solved that part of the equation. It was very hard. But that's what color Doppler is about. So all these small areas, small sample volumes, quote unquote, with an autocorrelator as opposed to a fast Fourier transform analysis to give me a quick idea what the velocity is. So if I have something like in red is going coming towards me or whatever, some circular, it's a blue is going away from me. You have a scale here and beyond, let's say 60 cms per second is going to alias. So anything that is beyond 60 in this image will alias, right? So we'll give you different colors. We'll give you a mosaic kind of color. All right. And that's what obviously you use for various flows and regurgitation. Notice one thing also, that if you have a change in direction, you'll have an area of black. That's how you differentiate aliasing, pure aliasing, from change in direction. Why? Because here things are coming towards me, right, in the ascending aorta, so they're a reddish color. I'm perpendicular now, so there's a black zone because there's no Doppler shift, and then going away from me, it's blue. It is not an automated kind of thing. It is depending on gain. The frame rate is important. Nyquist limit is important. So you have to attend to all these kind of things. Then how do you optimize it? Since it's taken a chunk for you to be able to process all this, it will drop your frame rate. So you have to be knowledgeable. If you don't need that much depth, don't make it. If you don't need that much width, bring it down so you can optimize your frame rate of imaging. And also it's gain dependent. It's mild MR, mild AR, and little MS. And I could increase the gain, and here you go. You can increase whatever it is that you want to increase. Notice here, if I drop my Nyquist limit, meaning I start aliasing, I start emphasizing low velocities, I can make this mitral regurgitation tremendous, as opposed to this mitral regurgitation on the right side, which is the same, actually, but a Nyquist limit of 57. That's the same case on the left and on the right. And few times we were called from the operating room because somebody has played around with the scale and Nyquist limit, said, no, there's a new severe mitral regurgitation, could you please evaluate it? And all what it is, somebody played with the Nyquist limit, dropped it, so you emphasized all these low velocities and every little movement was there and was quite too impressive for you to be able to see that, okay? So these are, I think, important for you to keep in mind, going forward. And we'll have enough talks about mitral regurgitations and the like. I'm going to skip high PRF and we can talk about, and this is continuous wave Doppler. So now in continuous wave Doppler, I'm sending whatever frequency continuously and listening continuously along the same line. I'm going to pick up anything on the way. Anything on the road in that line, I'm going to pick it up. So if I have somebody with aortic stenosis, okay, just like this case here, but at the same time this individual has a dynamic obstruction inside the ventricle or a dynamic obstruction in the alveolar flow tract, all of them are going to be on top of each other. There's no range gating anymore. So you have to think in the unusual situation of something is funny, where's the signal coming from? Because I cannot tell. If there's only an aortic stenosis and nothing else in between, you can take it to the bank. If there are different signals and there's something else on the way, be careful. Tissue Doppler. Most of these color flow, you haven't seen anything in the tissue because since the inception of color Doppler, we've suppressed it. We did not want to take a look in there. We looked at it 15 years ago. And it's easy to suppress, and the reason for it is the signal from the muscle is quite different than the signal from the blood. The differences are very simple. One, the intensity is much stronger. You're hitting muscle, comes back, is very strong, intense. So you could put a filter on intensity. You could put a filter on velocity. The velocity in the muscle is so small compared to the velocity of the blood in the cavity. So you put these two filters, and that's why when you put your regular color Doppler, you only look at blood. You're not looking at muscle. If you want tissue Doppler, you can look at tissue and not blood. Now, pulse Doppler is important, and all the work on systolic function, diastolic function. We were reminiscing yesterday that, Dr. Naga's contribution 20 years ago, that's 20 years ago, this E over E prime from the E prime has been, in play for 20 years and used all over the world now. Speckle tracking. Once I saw this abstract about 20 years ago, 15 years ago, I said, this is it. There's no question about it. That's going to be a major change because always your eye was trying to follow where the speckles are going in time. And having a technology that follows speckles, these speckles of refraction and reflection of ultrasound, is the way to go. Then you could track where the muscle is going, where the motion is going, be it leaflets or otherwise. And you hear about strain. What strain is a deformation. Now, the most thing you hear about is global longitudinal strain from the apex. Heart is compressing every systole. That's why the numbers are negative, right? So if I start with 10 centimeter and I go to 8 centimeter, I have a change of minus 20%. If I lengthen, I have plus 20%. If I don't change, I have a 0%. That's strain. And our work nowadays is mostly to look at deformation of the heart and different things. So, we'll have a talk about it. But strain, you have to remember that with strain, you're looking at one vector. One vector. Longitudinal, circumferential, whatever it is, one vector. It's not the total deformation of that muscle. It's just one vector of it. The other thing is strain rate, which is supposedly really is among the better parameters for ventricular function or any function, motion. Problem with it has a lot of noise. But I'll give you an example of a low strain rate. So this is the same deformation. It's taken much longer than a faster strain rate. So strain rate, which is 1 over strain, basically derivative, tells you about ventricular function. And what do we talked about longitudinal strain. There's radial strain, shortening, circumferential strain, what's happening to the circumference end. So these are basically the 3 components of it. And nowadays it's automated. Actually, you could see it very nicely, so you don't have to draw anything. You could automate it. And normal, nice heart, you could see the negative strain in this normal heart. And basically here, there's somebody who's not doing as well. The strain is very, very low, and then the map is incredibly low. So the numbers usually for longitudinal strain normally is more negative than minus 17, 18. And this person has minus 2%, which is almost non-viable. Digital storage. We talk about it now, but there was a big invention first. But it's very important because now with digital technology, it's not only a retrieval, it's how do you interpret a study? I implore you to use as many of these in front of your eyes, because then your choice, your understanding, your interpretation, I know most of you use 4, I use 9, depending what you're comfortable with. But then I can scan what's going on in the heart and whether this image is foreshortened compared to the other, which one is giving me the best display, and then I can hone in and zoom on it and quantitate or interpret whichever way you want to do that. And I think that's beautiful. And 3D, came on board, my goodness, about 15 years ago now, certainly refined over the past 10 years, even more so over the past 5 years, and adds another resolution, which is the interplanar resolution, in addition to the what's called azimuthal resolution, in addition to the axial and lateral. Nowadays, I think with the refinement of technology, you could take a look at the 3D of a heart in almost single beat, really a truly real time in the past. And I've taken these actually among the first ones. And this is what year here? Can you see it? 2003. Okay, go. So 14 years ago. Okay, images were not bad, but I want you to think about it. You have basically a pyramid of 3D. That's your pyramid. It doesn't look good, right? Where it starts looking good is when you start playing with it, when you start cutting through inside, rendering it in 3D and so many other things. And nowadays, you can have what's called a high volume rate. So instead of frame rate, volume rate. So you could do imaging in 3D in real time, so you don't have to stitch images, stitch cycles. And I think it's really a great technology. Where the work will be, not only in strain, is improving the temporal resolution, but more importantly also the spatial resolution. However, some of these pictures, particularly with transesophageals, are really beautiful. So with transesophageal, you could almost take it to the bank on looking at the mitral valve. And I think that's really the way to go. If you're tangential, like an aortic valve, it may be a little more, but en face view, these are your best images from there. And areas of also further improvement is color Doppler to improve the frame rate. And some of the newer technologies actually are getting better and better over time. So I think we're very happy that things are improving in the world of 3D echocardiography. So if you take a look at the field is amazing. Still the same premise has not changed. Ultrasound, waves, packets, the crystals have not changed much. Yes, the engineering of transducers, the technology of transducers, how do you fire a transducer, the electronics of it, yes, but the principle is the same. Exciting special material that emits ultrasound that is sent to the body or whatever organ, reflected, and you ask mostly 2 questions. 1, how far, how intense, okay? And 2, did the ultrasound shift one way or another to tell me about velocity and so many other things. Now the beauty of this is A mode 1950, you could see it there. And then M mode, and then 2D, and then Doppler, then color Doppler, transesophageal, contrast harmonics, tissue Doppler, live 3D, speckle tracking, live 3D TEE, and miniaturization, because it is, among all the imaging modalities, it's the one that can be miniaturized to be put in your pocket. And those are improving. Now it has some color Doppler, it doesn't have spectral, but ultimately will. And I would invite you to see the review that Dr. Shamsi Pasha put together. It's not yet accepted, but hopefully it will be in circulation, hopefully a couple of months from now, telling you about the utilization of pocket ultrasound. I'm going to leave you with this to reminisce over time. This is Dr. Ingi Adler coming into play. This is a patient of his. This is 1960. Not too far out. Not too far out. Let's see. He's going to come into the view. And that's his nurse. Maybe the sonographer of the past. I think of our sonographers, we're going to ask this code to be. There you go. And that's Dr. Ingi Adler himself taking a look at his patient. And he's so relaxed and puts his hand in his pocket. Take a look at the ultrasound and the oscilloscope, and you're going to see the A-mode technology. That was it. Right? Now, can you tell which one is the mitral valve and which was in? And I mean, it's amazing that within, 50 plus years, 57 years, right, that we've evolved so much into so many things using the same principles that he advocated. So thank you very much, and have a wonderful year of learning with us. Any questions? All right, if none, enjoy your day.